everyone, and welcome back to the Positive Veterinary Dentistry podcast, where we bring you real-world conversations about the future of veterinary dentistry and oral surgery. I'm your host, Benita Altier, licensed veterinary technician specialist in dentistry. Today's episode is one that I think every veterinary professional has encountered struggling with. Oral tumors and our veterinary patients, and more specifically, how do we truly understand what we're dealing with? How do we avoid making assumptions too early? And how do we guide our clients with confidence, even though we don't have all of the answers yet? Because this is one of our biggest themes and struggles, we're going to explore this today in more depth so that we can get some cutting-edge information from an expert in the field. So today, I'm honored to welcome Dr. Stephanie Goldschmidt. Dr. Goldschmidt is an assistant tenure-track professor in dentistry and oral surgery at the University of California at Davis. She completed her residency at the University of Wisconsin-Madison, where she also earned her undergraduate degree in animal science. She received her veterinary degree from the Royal School of Veterinary Studies at the University of Edinburgh in Scotland, and then went on to complete a rotating internship at the Veterinary Medical Center of Long Island. Following her residency, she spent 5 years as a clinical assistant professor at the University of Minnesota. She's also completed a fellowship training in both oral medicine at Penn Dental School and oral maxillofacial surgery at the University of California at Davis. Her subsequent specialty is subclinical, you have so many credentials. There's a lot of specialties here.
I know. I've been very busy. It's okay.
I often describe you as an overachiever. Okay.
I am.
Her subspecialty, clinical and research focus, is oral oncology with a particular interest in improving treatment paradigms using theranostic agents. So, Dr. Goldschmidt, welcome to the show.
Thank you for having me.
Of
I appreciate
course.
it.
Yeah. So excited to talk to you today. It's been a while since we worked together in person, but when we've taught classes to veterinarians out there in the world, it's been really fun to get to know you and to experience your level of expertise, knowledge, and your teaching style. You're such a great teacher and have so much to bring to the profession. I'm really excited to have you here today so that we can work together to bring light to this topic that I know you're really passionate about. I let my guests always pick the topic that they want to talk about because we all have our passion projects, and you've done a lot of research in this field at UC Davis and otherwise, and also being a oral maxillofacial surgeon, have a lot of expertise and treatment options that can potentially extend the patient's quality of life. So before we get started, I always at my podcast here have a question my last guest left for my next guest. So the last guest was Dr. Sandra Manfra-Moretta, and she asked you, what is your favorite maxillofacial surgery to perform, and why is that your favorite procedure?
Oh, I knew she was going to ask this. My favorite is an exonteration case, which means like a big caudal maxillectomy and then removing all of the contents behind the eye. Why it is my favorite is because it's technically challenging, just because of the anatomical limitations of the area, but also because a lot of people like assume these dogs are going to do so horribly with such a big surgery, and like I get to see them do really well and have a high quality of life and be cancer free for a surgery that a lot of people used to say was like not doable or uncuttable. So that's why.
Do you feel like that surgery has become not commonplace? Because I know this is only performed at your level with your level of training and expertise in oral maxillofacial surgery. But do you think that this is becoming more common at your level to perform such a seemingly undoable surgery?
I do. And I think that what's shifting is like a lot of people used to be like, oh, we can't do it. The dogs, it's not fair. The quality of life is so poor. And then now that more of us are doing it and other people are seeing it and they're like, oh, this dog got up the next day and ate breakfast and is playing and eating and doing great. It's starting to shift like what is possible and what like it's always very hard with oral cancer surgery. We always need to balance the ethics. Just because we can doesn't mean we should. Right. But I think that now we're seeing that these surgeries, they do so well, so more people are doing
all you
them.
need to do is have some case examples where you see success. And I have always said the animal's going to choose to live. They're going to choose life. And if we have the ability to give that to them and we can, like, why not? And just seeing
Mhm.
their behavior in that they just want to play, they just want to eat, and they
Yeah.
just want to be feeling well and wanting to interact with their owners and families. So that's amazing that you're able to do things like that. And medicine and veterinary specifically has come this far for these patients. I
Yeah.
would love to see more information about that because I didn't even realize that's something that we're doing in vet medicine. Yeah.
Yeah.
So
Yeah.
when we think about general practitioners and what they've been taught in veterinary school and what they've encountered out there in the real world, from the research that I've read that you helped to publish in JAVMA, we may really be under treating oral tumors and not working them up as we should early on, given the most current information that you have. So, what should a general practitioner be thinking when they see something in the mouth that they're suspicious of? What should their first steps be without making assumptions based on the way the tumor appears visually? And what do you think that they should be thinking?
Yeah. So I think a big misstep is that we look at something and we're like, "Oh, it's benign," or "Oh, it's nothing." So definitely a biopsy is essential. I have been tricked before where something looks really boring and is a fibrosarcoma. So the order of when you do the biopsy, I think depends on the conversation with the client, right? Some clients say, "I want to get a biopsy or cytology," which can be diagnostic sometimes. It often is not. The mouth doesn't exfoliate that well. It's not wrong to try, but to get an initial answer so that they can then say, okay, I want to stage or not stage. Once we know a tumor is malignant, staging is a non negotiable because it's really going to change how we treat these clients, the amount of time we're going to get with surgery or other treatment, and how they make those decisions. So, staging in general at a GP level definitely should include chest x rays. That's going to definitely let us know if there's anything scary happening in the chest, and then checking the lymph nodes. From the mouth, the way that it drains the lymph nodes is a little unpredictable. So it can sometimes go to either side. It can also sometimes go to deeper lymph nodes. But I would say a great baseline is both mandibulars, which we can palpate easily. So getting chest x-rays, mandibular cytology can give us a good first line picture of what's happening. And it depends on the client. Some say, I don't want to do a biopsy if there's chest mets. So you do your x-rays first. Some say, I don't want to spend the money for x-rays and a workup if we found out it was gingival hyperplasia. So some want to do biopsy first. And I think it's just laying it out for everyone and seeing which way they want to go. But a big problem that I think I see the back end is for years they said, oh, it's nothing, it's nothing, it's nothing. Wait till it's huge. And now we've missed our window, or maybe there's still a window, but it's so much higher morbidity. So I think underlying the importance of a diagnosis early to clients is really
Yeah.
important.
And we don't want to get to the point where we have to send a patient to you for a really radical caudal maxillary surgery. I know it's your favorite, but we don't want to get to that point. And from reading your published
Yeah.
works, it really seems making assumptions really leads us down the wrong path. So, a couple of things that stuck out to me was one, just because it's small doesn't mean it's nothing, right? And then
Yeah, totally.
two, because it's large doesn't mean it's something really bad, right? So there's just so much more information that we need before we can decide. And also looking for spread to the lymph nodes or elsewhere. We definitely don't necessarily just depend on palpation of those lymph nodes because that doesn't really, it can also deceive us as well. So where do you think some of those types of things could help drive a practitioner to, I guess, be more thorough right up front and to use the right
Mhm.
words to get the client to understand specific steps that would be ideal versus them just saying, well, I don't think it's anything, or it's small, let's wait and see what happens. Because that client's always going to err on not spending money or not putting their pet under anesthesia, right?
Yeah, totally. I think that's something that someone once told me when I was early in my career was like, clients are going to do what you suggest is the better option. So, like, when you come in the room and you're like, oh, I see this mass, but it's probably nothing, but we should biopsy it. Of course, they're not going to want to biopsy it now, right? Like, you just told them that you don't think it's anything. So I normally go in and I say, we see this oral mass in the mouth. We can see things that are benign or malignant. I think this is most likely benign, but the only way for us to know and to properly give prognosis and treatment recommendations is to get a sample. And that is what I would strongly recommend. And like you mentioned, we know that 40% of palpably normal nodes harbor metastatic disease. So normally once you tell an owner that, like, because the first thing they'll say, oh, I want to sample the lymph node. Oh, but they weren't big, right? And then I just explained to them, yes, but like we know that palpably normal nodes are very likely to harbor metastatic disease. And that would vastly change our prognosis and maybe means that you don't want to treat or you just want to palliate. So it's a very important piece of information to have and definitely could change our treatment plan. The other thing we talked a lot about in that paper, which I feel like it's a good time to bring up now, is even when a tumor is benign, like the odontogenic tumors, the ameloblastomas, we do still recommend screening, we call it, instead of staging, because these dogs are old and often we'll pick up other incidental things. So especially on the abdominal ultrasound, we recommend that for every patient. And we're really not looking for mets. We're looking for, is there a mucocele? Is there another tumor that might prevent us from wanting to do a maxillofacial surgery? And the likelihood of finding that is low, so 9% to be exact, but that's 1 in 12 dogs, right? And if it's your dog, it's
Yep, that
100%
makes a
of the
big
time.
difference if it's your
It's
dog. So we have to think about that, I think, with every single patient because we can think, well, statistically, this is their
yeah,
baby and we don't want to take a chance and we don't want to minimize the impact that would have on them and their relationship with their pet or just being able to have their pet in their life or their pet having a life that's good quality.
exactly. And that's how I approach it is I offer them the Ferrari, which would be regardless of what type of tumor it is, anything that is truly a tumor, and we're going to be doing a surgery, benign or malignant, essentially screening. So making sure we're not picking up anything else incidental that might preclude us from wanting to move forward. And we know that when we do all four, like we do a head CT, we test the lymph nodes, the chest and the belly, there's a 1 in 4 chance we'll find something. So it makes a huge difference for these patients. And when we explain that to our clients, I I know we have a biased population that I get to see, but everyone has been like, that makes total sense, right? And want that information to make the best
Yeah.
decision we
And I
can.
think in most general practices, a lot of these imaging modalities and the ability to get this information is pretty readily available now. 20 years ago, 15 years ago, that might not have been the case, but I think most people do have the ability to do quite a bit of this in hospital and
Mhm.
also have referral practices that could do these things not too far away, which helps a lot if the client's willing to go for this. But the client hears the word tumor or a mass, they may be
Mm.
panicking because they're thinking cancer. Oh no, we're going to have to make a euthanasia decision. Like their mind just probably jumps to the worst of the worst things. So, as a general
Totally.
practitioner, we probably have to really pre prepare what we're going to say to someone because, as you mentioned, someone saying, well, it's probably nothing, that's our hope internally. But when we say that out loud, I think we're really minimizing the sense of urgency to that client that, you know what, this could have been percolating in the mouth for a long time. And because of the fact that we don't anesthetize these animals frequently enough, we often find
Mhm.
something while they're under anesthesia for something else, or when they're under anesthesia for a routine dental procedure. So it's incidental finding. I can't tell you how many patients over the years that we were anesthetizing for dentistry and we found something in there that no one could have seen other than when we got them completely anesthetized. So we want to be, as I think, taking this as our one opportunity to get aggressive enough with the pre-work that if it's nothing, then great. But if it's not,
Yeah,
why take that
absolutely.
chance, right? Of just putting it
Mhm.
off, which is always everyone's human nature. We want to put off something, especially if it's scary. So, abdominal ultrasound, lymph node
Mhm.
aspirations, and then
Mhm.
chest rads and in your world, you have cone beam CT as well, but what about
Mhm.
dental radiographs or intraoral radiographs? What type of role does that play when it comes to looking at these types of masses, whether they're teeny tiny, something that we barely notice, or something even fairly large?
Yeah, I think that at the time of biopsy, it is great to have a dental radiograph, especially if we're deciding between an odontogenic and non-odontogenic tumor, or even within the odontogenic tumor realm. There are certain ones that don't eat into bone at all. So knowing that and giving your pathologist that information is very helpful. I think it also helps with talking about the urgency for the client. So you see a little nothing gingival mass, but you say, hey, we're going to see what it is. And you take an x-ray and now there's also bone lysis. Now you have more credence to say, hey, this looks like it's something more scary. We know from people that bone lysis is extremely painful. Like these are all the reasons we need to think about either treating with radiation or surgery once we know what it is, or talking more strongly about what palliative care looks like. So I think having dental radiographs, if that's something you can do at the time of biopsy, is
Okay.
excellent.
And if we're going to be putting them under anesthesia, then obviously, if they're under a general anesthetic, we could definitely take the radiographs. And like you said, giving that information to the histopathologist along with the other samples and information. I always tell people to make sure to take photographs of the mass,
Mhm.
to use calipers or even your Explorer probe instrument, because your probe has 1 millimeter markings on it to get dimensions. Besides photos, radiographs, dimensions, is there anything else that you recommend that people do when it comes to preparing to send a biopsy to the histopathologist?
Yeah. Well, one, that's like, please, please, please take a photo. Bonita said that's
Yeah.
so helpful. But also the size. So, like, especially for melanoma, for example, we actually have data that for every centimeter larger a melanoma is, there's a 30% increase in the hazard of death. So knowing the size of that melanoma and any tumor, but melanoma more than anything, is super prognostically impactful. So a T1 staged clean melanoma with surgery can get 2 to 3 years. Once we get to like a stage 2, it's over 2 centimeters, it like drops to about a year. So it's a huge difference just with that increase in size. So that's really important when we're talking to the client. The other thing I would strongly recommend to not do an excisional biopsy. So taking that tumor in entirety, it like feels very rewarding. But the problem is often if it truly is malignant, you're leaving cells behind. And because we can't totally see where it was or what was left over, our next surgery can actually be much challenging and larger because it was taken in entirety. So taking just a punch in the middle is usually the best way for surgical planning
That's great
later.
advice, and that's something I've definitely heard in the past. And I think that the tendency is to want to look at a mass just visually inspecting it and thinking, "Oh, I think I could remove the whole thing," realizing that you should not for those reasons. Go ahead and just get a
Mhm.
biopsy, do your staging, and figure out what exactly you're dealing with and whether this is something that should be accomplished in your hands versus referral to someone who has more imaging modalities like cone beam CT and additional surgical experience like yourself.
And I will say that for an oral tumor, we don't wanna be using
Mhm.
cone beam CT, we wanna be using real CT
Okay.
with
So
contrast.
not cone beam
Mhm.
CT, so real CT with contrast.
Yeah, just because cone beam can only
Mhm.
see bone, so we want these to have something that you can give IV contrast and see the soft tissue extent of the
Got
mass
you.
as well.
That's great. And that's more likely going to be in a university setting to have a full cone beam or a specialty.
Yeah, I would say any referral practice usually will have a full contrast CT if they have multiple
Okay.
specialists on hand. Some standalone dental practices will
Mhm.
only have cone beam, but most of them have the ability to refer out for a true
Okay.
contrast CT.
That's great. Also, when we think about the biopsy, when we think about who we send that biopsy out to, are there any specific histopathologists that you feel should be consulted regarding biopsies of masses in the oral cavity versus where someone might send their regular biopsies for masses on the body?
Yes, that is a great point. And there are specialists in oral pathology. My personal favorite is Cindy Bell, who runs SOPA, or the Specialty Oral Pathology for Animals. She does tend to be a little overworked, so I do try to reserve like very challenging masses for maybe her to get a second opinion. For just general oral pathology, there are also some great oral pathologists at the main places like IDEX and Antec. They both have oral pathology teams. You just have to ask for it specifically. So like Melissa Sanchez, Alex Harvey, Barb Powers, they're all great oral pathologists as well. Normally, if it is a fairly easy mass, anyone can diagnose it. But if it is something more challenging, definitely asking for that oral pathology team can make a big difference in figuring out what it is and then stratifying your treatment.
Great information. And a lot of veterinary practices use those reference labs. And those would be the people that they need to specifically try to designate for that particular biopsy, especially if they're really concerned that it could be something more aggressive or difficult to diagnose, I would assume.
Mm-hmm. Yeah. And I think it's very easy. Like, I think when you send it in, you just check, like, I want this to be looked at by the oral pathology team. And I could be wrong, so I don't want to misspeak, but I don't think there is an additional charge. I think it just streamlines it to that team to make sure they're the ones looking at it.
Yeah, that makes sense. We want the people that are really in tune to oral pathologies. Now, with dogs specifically, what can appear to be something really concerning, but is actually benign? Like, what type of tumors do we see that actually look really scary, but are not actually that concerning?
So what I would say is that would be like the camp of the odontogenic tumors. So within the oral cavity, we are a little bit unique that we can have these tumors that come up the teeth themselves called the odontogenic tumors. And they used to be called epili, but we largely kind of try to get away from using that word because it really confers that they're totally benign. But some of them can get extremely large and destructive. The most common one that kind of can look the most destructive and the scariest would be the ameloblastoma. So it can eat into bone quite aggressively and also become very largely cystic. But it can start by looking like a little gingival nothing. And then once it gets into bone, get really large. So sometimes when you see them on imaging, you're like, holy smokes, this is so aggressive, so enormous. However, because they don't carry any metastatic potential, even with surgery, they can be cured. So a lot of times we'll see people dissuading, oh, you have this horrible tumor, but because it's an ameloblastoma, if they would move forward with surgery, we can cure these patients, even if it's really big. A similar type of odontogenic tumor would be the peripheral odontogenic fibroma, or the POF. They don't eat into bone at all. So that's where dental radiographs could be helpful. But I have seen them, when they're ignored, get extremely large and look like a fibrosarc. Right. And this is one of those things where a biopsy would tell us this is not a fibrosarcoma. We can cure this dog with surgery. And for POFs, we don't even need a margin. It literally is just removal of the mass itself, and they can ride off into the sunset.
Which is what we want them to do, right off into the sunset. Happy dogs. Are these odontogenic tumors often occurring in younger dogs, or what age group do we often see these?
Both POFs and ameloblastomas we tend to see in middle-aged dogs, but both have been reported in young dogs as well. The odontogenic tumor we see primarily in young dogs are odontomas, which are the type of odontogenic tumors that make teeth. So they're very cool to see, and we see them usually in dogs less than a year. I have seen ameloblastomas, though, in 1 or 2-year-old dogs, so it's not unheard of. But in general, we tend to see more around the 6 to 9-year-old range.
Okay. So we want to be screening these dogs all the time throughout their life, but we do know specifically that there's some oral tumors that could pop up at certain age groups, leading us towards that particular diagnosis, or at least having an idea how to stage that patient or potential treatments for that patient based a little bit on how old they happen to be. With some of these tumors that we see in the mouth of a dog, is there any specifically that you would say often tend to look like nothing, but are a lot more concerning just based on visual inspection?
Yeah, I would say the biggest masquerader would be squame. A lot of times they look like ulcerative lesions. So like you have this non-healing wound or an ulcer on the palate and it's just not getting better, not getting better. I would be worried that it potentially is a carcinoma and definitely want to biopsy that. I would say the other thing I see a lot that people think is nothing and ends up being something is a swelling right under the eye. And everyone says, "Oh, it's a tooth root abscess. Oh, it's a tooth root abscess. Oh, it's a tooth
Or
root."
a spider bite,
Yes.
right? That's what people think, "Oh, he must have been bitten something
Mhm.
on his cheek," then we get to the hopefully the veterinarian, the general practitioner realizes a draining fistulous thing underneath the eye is often dental origin, right? So hopefully
Mhm.
we're heading down the right path, but now we're dealing with something maybe more sinister.
Yeah, I've seen a number of fibrosarcomas in this location in particular where
Hmm.
they didn't respond to antibiotics, they didn't respond to antibiotics, and then they let it go for months and months and months, and then by the time we see them, they're very large, and it's tricky because we don't see anything in the mouth, right? I just because we don't see a mass effect in the mouth doesn't mean it's not a cancer. So anytime something like is fishy, like it's a
Mhm.
non-healing wound, it's not responding as we would expect, that's always like perks up my ears that like we definitely should biopsy this and see if we're missing something. And that's why our normal medical treatments aren't working.
Right. That's a big red flag if things aren't healing and it seems like what you did made sense at the time, but what's going on, right? We
Mhm.
need to get more aggressive on figuring that out versus waiting because, especially with these animals, their little lives are so sped up. Things can rapidly change. And we think a month or two is nothing in our lifetime, but for them, it could be a really big make or break situation waiting too long to kind of get
Absolutely.
to the bottom of it.
And we hear all the time from patients like who come here, "Oh, I wish I caught it earlier." "Oh, like, what do you think? I was nervous about
Mhm.
this thing." And so I think if there's anything suspicious, it's always better just to get a sample of it. If the worst case scenario is that you find out it's nothing, that's a pretty good scenario to be in. So I think it's actually just phrasing it to the clients more in that light of, "Hey, let's just make sure." And wonderful if it's nothing, right? Like, then we can not worry about it rather than waiting, waiting, waiting till it declares itself.
Yeah, good news is good news.
Yeah.
So I always heard about there was some specific oral tumors that would displace teeth or
Mhm.
move teeth out of the way, and some where they don't do that. So can you explain a little bit better for me? Like, why would an oral mass cause teeth to move out of the way versus stay in place?
Yeah, so the thought process behind it is that, like, slowly growing masses, like POFs, which don't cause bone lysis but will grow, can slowly move a tooth, versus aggressive oral mass that is extremely lytic will eat into the bone and then the tooth will be mobile. It's a little bit of like an old wives' tale, but I will say that it is normally the pattern we see. So it is
Okay.
true. Like if a tooth is moved, it probably is something that happens slower. I don't think it totally means they're benign or not because I've seen a fibrosarcoma also move teeth, but it means that
Mhm.
there's a mass that is growing that isn't eating the bone away. Versus if teeth are mobile, the bone is being eaten away, which usually means it's happening faster, more aggressively.
Exactly. And this is where dental radiographs can really start to show us even subtle changes to see teeth being moved slowly out of
Mhm.
place. And that's concerning because generally speaking, teeth move into the place they're going to be and stay there and don't start drifting or moving or anything like that in veterinary patients,
Yeah,
right?
if a tooth is moving at all, that's not normal. In
Mhm.
humans, our teeth move with time. We have different fibers than dogs, and so in dogs, even when teeth are extracted, teeth shouldn't shift. So if a tooth is shifting, it means something is growing or pushing it. If it is happening slowly, it might be that it is not a fibrosarcoma, it might be more of a POF, but it's definitely reason to look for imaging.
Teeth in dogs are a natural retainer, basically, right? When they are in occlusion versus with people, we have different occlusal forces as well, which can cause that to happen if teeth are extracted and now there's a gap, right?
Mhm.
So, very fascinating between humans and dogs. When we think about whether they are pigmented masses, are there anything specific that you have as like other red flags or indicators that we should be more considering something versus something else with pigmentation of masses?
Yeah, I mean, really the only mass that's going to be pigmented is a melanoma. There is this thought that actually amelanotic or unpigmented melanomas are worse. We don't actually necessarily know that. It's actually the opposite, which is interesting. Like if there's something that's very dark and very pigmented, it means that the melanocytes are well differentiated, which actually means it's a little bit less aggressive than one that's not doing that pigment. But there's no good studies that show that the amelanotic ones are worse, but we know the very well pigmented ones are better. If you see a truly pigmented mass, it probably is a melanoma. But something that always gets me down in the dumps is someone sees a little pigmented mass, they tell an owner it's a melanoma, it's a horrible prognosis, don't do anything. But in reality, if it's a small melanoma that we caught early, it's well differentiated, like those well pigmented ones, stage is clean, and we do surgery, they could get 800 plus days. So they can still do well with intervention. So don't put them in this doom and gloom category right away. Kind of give them the information that these are highly metastatic, but do you want to see if it has spread? Do you want to move forward with thinking about treatment? But definitely any well pigmented mass within the mouth, it's most likely a melanoma, and you definitely should get biopsy to confirm that and talk to the owner about next steps.
And this can get confusing because sometimes inside the mouth, there's these pigmented places, right? And especially owners, they don't often look in their pet's mouth that carefully. So they might think, oh, is that something new? Or has he always had that dark spot right there? So definitely not taking that and just discarding that information. We should be looking at it. But I assume if it's a mass, it's not going to be just normal tightly attached gingival
Yeah.
tissue or mucous membranes. It's going to be a different texture or raised or rolled or something else that would clue us into that we should be looking at it as more of an isolated area versus something that's just part of the normal anatomy,
Yeah,
right?
absolutely. It's normally not, it's very not impossible, but it's very rare for melanomas to be flat, like truly just like a pigment in the mucosa. It's more that like they come out as a mass and they normally do grow quickly. So often they will have some ulceration, some rapid change. There is this kind of subsets referred to as well differentiated melanocytic neoplasms. Some call them melanocytomas. So there is this like more benign subset of melanomas, but are rare and tend to definitely be like right around the lips or mucocutaneous junction. They're not normally true oral, but most of them are truly masses. I've never seen a melanoma that's just a new pigmented plaque or flat area.
Okay. And I assume that caudal melanomas also are more concerning and less often recognized than ones in the rostral part of the mouth.
Yeah, biologically, they're not worse, right? Caudal is not worse than rostral, but normally we pick them up later. Surgery becomes more challenging, I'll bet not impossible. So definitely something I give the same spiel to everyone. So I never say, oh, you have a caudal melanoma, this is a death sentence. I say you have this melanoma or with likely melanoma, it's going to biopsy to confirm. And then if you want to move forward, let's get all the information from staging. But if you have a T1 or T2, melanoma that truly stages clean, the literature says that we can still do well with surgery. The best, obviously, the smaller the better, but even for T2s, we tell them about a year, but there are some papers where they get 2+ years. When we get bigger than 4 centimeters or lymph node spread, that's normally when I have more of the conversation of a more guarded prognosis. We're looking more kind of at 6 months or so. And then we talk about, do you want to move forward or do you want to just do palliation? But I think it's a big mistake telling someone right from the beginning when you see something, oh, this is melanoma, it's horrible, we can't do anything. Because for some people getting 2 years, they're really happy with that amount of time and they would want to move forward.
That could be a long time, especially in a larger dog's life.
Yeah.
Yeah. I think reading some of your work as well, there was a large number of dogs in the studies that were larger dogs like Labradors or Retrievers. And we do know that there's some breeds that just seem to be having more than their fair share of these types of tumors. Is there anything specifically that we're working on? I know I remember reading something about a vaccine for melanoma, but these at-risk breeds, is there anything right now in the research that are being worked on to help us predict, treat, or prevent for some of these dogs that are more at risk?
Yeah, we definitely know that large breed dogs are more predisposed, especially golden retrievers, that we tend to see more oral cancer in them. We are working on it. We are looking at like what are essentially biomarkers of disease that we could catch early. So what we've been looking at is we've been looking at dogs that have oral cancer and then the kind of surrounding tissue right near it, which we call dysplastic tissue or starting to look a little abnormal and seeing what is in those dysplastic subsets. So what genetically is happening there, and could we actually use that to do saliva swabs to start pre-screening for dogs. So that's something that we are actively working on here, trying to see if there's a better way for us to pick them up. As far as treatment, there is the melanoma vaccine. So melanoma is very interesting because it's what we call like an immunogenic tumor. It's very smart. It's very good at evading the immune system. So essentially hijacking that to try to wake the immune system up. So we call it a vaccine, but it's not really preventative. It's given after to wake up the immune system. It has had mixed results. Essentially, one study showed it's better than sliced bread. One study showed it didn't work. I tell people the only thing it's going to hurt is your pocketbook. We know it is safe. We just don't know if it actually works. So definitely it's not wrong to give it, but I would give it as an adjunct to another local treatment. I wouldn't give it as a sole treatment. We are actively here working on some of our own immunotherapeutics, similarly for melanoma, to try to wake up the immune system to better fight off cancer. And that's some of the clinical trials we're working on now. So looking at a checkpoint inhibitor, actually, we're about to start it soon, any day now, looking at giving that before surgery. And could we wake up the immune system and do better? But right now, everything's in the works. There's nothing that's really come on commercially that can be used in practice right now.
Okay, that's good. And it's so reassuring that there's people like you at the university level working on this research to really help us get down to the bottom of how to recognize this and prevent it ideally, but recognize it as early as possible and have some really great treatment options. So, right now, it sounds like from what we're discussing that the staging is really important and that we don't want to neglect to do the full staging
Yeah.
if at all possible, so that we can give the pet parents the most information we can so they can make an educated decision on what they want to do with their pet. And that we have to be really careful with our biopsy technique, right? So that we're not going to cause more struggle for a surgeon like yourself to hopefully get a cure through a surgical intervention. Besides surgery, what other adjunct treatments are there out there for some of these cancerous tumors that we really have to be more aggressive about?
Yeah. So, in general, when we think about local therapy, we're thinking about surgery or radiation. So, radiation therapy, a lot of these are radiation responsive. The biggest thing, like when I give my spiel to clients, is that cells can escape radiation. So, when we give radiation, kind of one of the biggest things we worry about is that some cells do not die and the local recurrence rate is potentially higher. And we know that especially for squamous cell carcinoma. But sometimes for certain melanomas that they're bigger and surgery would be high morbidity, radiation's a better option, right? Because we don't have that same morbidity from surgery. The side effects we think about with radiation would be oral mucositis, like a hot pizza burn. I've warned people about a hot pizza burn, and then sometimes they can get some kind of hair changes. Those are the kind of acute side effects. Long-term side effects, if that is the outcome that they get, we can get what's called radiation-induced osteonecrosis, meaning some of the bone dies because of the radiation. It's rare, but is possible. Normally happens a year plus after RT. And then we can have some changes to the eyes and some long-term kind of like fibrotic scarring changes. But in general, they do tend to tolerate radiation pretty well, and it's a good alternative if they don't want to move forward with surgery. The kind of chemotherapeutics or systemic medications, those are really only for patients once they've had spread. So that is not a local treatment. It's normally if we already have lymph node spread or chest spread, then that's when we think about adding those on. And it's rare, but sometimes we will give those kind of therapies before surgery to try to shrink down the tumors, but it's definitely a more unusual approach.
Well, and that could be less scary for a pet parent too if they know that this doesn't necessarily mean chemotherapy, right? Because a
Totally.
lot of people think cancer and they think chemotherapy and they think my pet's hair is going to fall out and they're going to be vomiting all the time and they're going to feel horrible. And I don't want to put my pet through that. But as we talked about earlier, they just want to live. They just want to eat their food. They want to play. So it's amazing to me how well they really tolerate some of these interventions, given what a human might wind up having trouble with these types of treatments.
And I
So,
always tell them, like, they don't look in the mirror. Like, the
right.
hardest right, the hardest part for us to have a piece of your jaw removed is, like, the social aspect of it, but they don't have any of that. They don't look in the mirror, they don't have the cosmetic piece of it, and they do amazing, like, the amount that they can adapt to having a piece of their jaw removed and eating the next morning, and they hunt, and they play, and carry around
Mhm.
big sticks, and usually
Yeah.
the first kind of 5 days are the toughest, but then they turn this corner and they go back to their normal quality of life.
Exactly. They probably get more sympathy and more
Yeah,
pets and more hugs, right? Because they're like, "Oh, buddy,
exactly.
what's going on with you?" And more people paying attention to them, so they probably enjoy that extra
Extra TLC.
attention.
Yeah.
A little extra TLC. One thing I wanted to bring up before we got to the kind of last thing I wanted to ask you about was tumor seeding. So we
Mhm.
talk a lot about nerve blocks, and I always talk about if there is a tumor, we don't want to be placing an injectable drug through that tumor to apply a nerve block. So, are there any specific things when we talk about pain management with these pets that we should do or shouldn't do or just be cautious about?
Yeah, totally. So what you brought up is a great point. We never want to use an instrument and go through a tumor and go somewhere else, especially a carcinoma. So if you are going to do a local block, which we always recommend, don't go through the tumor, do a farther block. If you can't get away with a block, better to not do one at all. Similarly, make sure you're changing your instrument. So if you see it on your oral exam, make sure you probe that last. Don't use the same scalpel that you use there anywhere else because we worry about seeding. As far
Mhm.
as pain control, these are painful. These are painful because they eat into the bone. Normally, the best things we can do are an NSAID if they can tolerate it. NSAIDs tend to be really good for bone pain. And then you could add on amantadine or gabapentin as well if you need a backup. But normally, the best thing we can do is get rid of that bone pain by surgically removing it or radiating it. If they decide to do neither of those things to deal with the bone lysis, then for more chronic pain, I usually do long-term NSAIDs, gabapentin, potentially amantadine, and then an opioid for true hospice care. So once, like, if they've decided they don't want to treat, they just want to medicate, then towards more the end of life hospice care, I will do short-term fentanyl patches so they can be as comfortable as possible at the end.
Yeah, that's important. We want these guys to be comfortable. And during the surgery itself, do you use controlled rate infusions as well as your nerve blocks? Is that
Yeah.
something you would do as well?
When we're doing that, not for a biopsy, just because it's too quick. Normally, we'll just do a single opioid injection. But for maxillectomies and mandibulectomies, yeah, we always have them on, usually a fentanyl CRI, plus or minus a ketamine CRI, depending how invasive the surgery is. And then we normally keep those on post op for about 24 hours.
We love CRIs for dentistry. I feel like they were made for these
Yeah.
cases that you have multiple quadrants involved with maybe major extractions and also just dealing with the fact that I definitely learned from you even more about this. Sometimes nerve blocks don't work. And
Totally. Yeah.
I'm like, but why? you
Yes,
know,
but sometimes they just don't work. Yeah.
they just yeah, they like you said, metabolic alteration of the tissues, right, can
Yeah.
really interfere with the ability for those nerve blocks to work for our patients. So we have to have other potential ways of dealing with not only intraoperative pain, postoperative pain, but then maybe even longer term when it comes to these patients having some major surgery.
Yeah. Totally.
So one word that was coming up in your literature that I was unfamiliar with is
Theranostic
theragnostics.
theranostics.
Diagnostics? Yes.
Yeah.
So explain this to the audience just so we can have a better understanding of what that means and how that applies.
Yeah, so theranostics are probes that are both therapeutic and diagnostic. So, something that, as much as I like to do surgery, what I find very hard is when we go for an oral tumor surgery, we take the tumor, then we take a centimeter up to 2 centimeters around the tumor to make sure no cancer cells are left behind and we give the best chance of a surgical remission. But that has a lot of morbidity in the oral cavity in particular, especially like a small dog, 2 centimeters every direction. That's a big surgery. So a lot of my research focuses on how could we better tell cancer from normal tissue in real time by using these kind of probes. But theranostic probes also treat the cancer itself. So they have some sort of anti-cancer killing, but also help us guide in the OR. So that's what most of my current research focuses on.
That's great because we don't want to have him lose a larger amount of his face if we could just pinpoint where the treatment needs to be applied. So rather than ruining the whole neighborhood, you're actually just hitting the one place, the house where the tumor lives, right?
Exactly. Yeah.
Yeah, that's really exciting and neat that you're doing more research into how we can expand upon this concept and really be able to improve staging and margins and targeted therapy for all of our patients that we need to work on. And so this isn't just a dog thing. I'm assuming we're talking any animal.
Yes. Yeah. So we're definitely spending a lot of time also on how we can better treat cats with oral squamous cell carcinoma, which is obviously very challenging for all of us because right now we have no good option, right? So
Yeah.
it's definitely something that we're actively looking at as well. So not dogs only, but
Right.
dogs
Right.
and cats. Yeah.
Exactly. It's just with cats, it's really challenging because often these squamous cell carcinomas seem to pop up out of nowhere and they can tend to be in the back of the mouth and it's not recognized quickly enough, even if there was something that we could do to really help this cat. So that's a really challenging one. But talking about dogs today, it really, I think, gives us some hope that we do have some really good, solid information here that we can use when we're talking with clients. Thank you so much for your scripts and things that you would say to the clients once they present to you at a high level there at UC Davis. Even in a general practice setting, I think it's so incredibly important that we understand the words that we say and what we do really can make or break the situation for that pet. It could be life or death. They could decide that they're just going to euthanize, even though maybe that wasn't necessarily the option that would have really helped that animal for short term or longer term without really too much heavy lifting, honestly, or at least getting the information to make an educated decision so that
Yeah.
these clients aren't jumping to conclusions and their pet has a death sentence and there's nothing they can do. So it's great to remember that. With this conversation, what do you think you'd really like the listeners to take away from this? Any things that you would think are key that you really want to reiterate about what we talked about today?
Yeah, I think you did a very good job, like, just summarizing it, but I think the most important things are don't let assumptions get the best of everyone. I think that coming in and saying, "We see something, let's find out what it is. Let's do a quick biopsy or try cytology to have more information, get the whole prognostic picture," and letting people know that there are options for these masses. They don't have to take them, but giving them all the information and then letting them make the decision rather than saying, "Oh, it's melanoma, all melanomas die." Right? And not giving them all that information and going through the staging and going through the biopsy. I think there's so much power in what can be done before they even come to see us, and that having that conversation is so impactful.
Very important advice and things that the DVMs out there in general practice will really be able to take away. So we're going to link these two papers, part 1 and part 2, that were published in JAVMA in the show notes. And if there's anything else that you think would be relevant, we can certainly add that to the show notes as well. They can find you at UC Davis doing all your great work there with the team and doing your research, which we'll watch for more publications and updated information from your work there at UC Davis to help guide our clinical decision making, because that's what this podcast really is about, bringing really up-to-date clinical information and relevant topics to general practitioners, veterinary technicians, and teams out there in the world, because we sometimes just don't have a lot of time to dive into the research, but having more of a concise conversation about it today could really help spur on some curiosity to want to learn more, and then don't jump to conclusions for these patients so that we can hopefully slow down and get the prognosis figured out and figure out what we're dealing with before we just jump to something really devastating for this patient. And they're people, right?
Mm-hmm.
Yeah. So before we sign off today, you get to leave a question for our next guest. So did you happen to think of a question that someone like yourself or a veterinary technician like myself would be able to answer?
I was going to ask, what is the favorite animal you've ever treated?
Okay.
Yes.
What is your favorite animal that you've ever treated?
Yeah.
Perfect. So that question will go to the next guest. So watch for that answer. So I have to start listening to the podcast.
There you go.
So you can listen for the answers and the questions as they come along.
Yeah.
So thank you so much today, Dr. Goldschmidt. I really appreciate you being here and bringing your expertise. And for the listeners, thank you for being here to listen to the Positive Veterinary Dentistry podcast. We really appreciate you listening. Please like, subscribe, and share, because we're trying to make sure this information, which we feel is so vital to our general practitioners, gets out into the world. I'm sure you have other veterinarians and friends that would be interested in this information, so please share this episode with them. And until the next episode, keep doing positive dentistry, listen in, and we'll see you next time. Thank you.